Okay, welcome back, and welcome to our next group of panelists. At the last panel, Tom App mentioned that we should be very cautious about applying the public health rubric to discussions on gun violence. While it's important, he said, as an extra dimension, it's not the one and only answer, which of course we know, but to really unpack a little bit more about the public health approach. We have our really distinguished group of people and speakers for our next panel, and I'll let Maurice introduce them all. So welcome, everyone.
Welcome, everyone. There are longer bios in the panelist bio group, but with us today and presenting first is Fatimah Loren Dreyer, who is the Executive Director of the Health Alliance for Violence Intervention, HAVI. And she's going to talk to us about, what is this and what do they do and what works. And then we have Shani Buggs, who's assistant professor with the Violence Prevention Research Project at UC Davis Health in Sacramento, California, and has done a lot of research and community level gun violence prevention programs. And then Dr. Noah Romo from Jacobi Medical Center in the Bronx is going to talk about the program that he has there. He's the medical director of the Pediatric Violent Trauma Follow-Up Clinic and the Bronx Stand Up to Violence program. And so without further ado, I'm going to turn it over to Fatimah and take it away.
Thank you so much. I have slides to share, so I'm going to share my screen in a moment. Hopefully this works. Oh, I see. I can't do it. There's always that pause, right? The moment when you've got to press share. Can you all see my screen? Yeah. Okay, you all see it. Okay, terrific. Well, thanks to all of you. My name is Fatimah Dreyer, Executive Director of the Health Alliance for Violence Intervention. We are a national organization that's been around for 12 years, and we help stand up hospital-linked violence intervention programs throughout the country. We're in over 85 cities, many of whom have been veterans who've been in the work of violence intervention for many years, and many emerging sites, places that have contacted us more recently and requested support to help build programs. In addition to helping stand up HVIPs, we really help facilitate communities of practice. So our members not only participate in their direct work on the ground, but support one another across communities to share best practices, to push innovation in the field. And on the advocacy side, we really work at the state and federal level to help uplift the workforce of violence intervention and prevention professionals, which I'll talk about shortly, and their vital role within the milieu of supports required to help transform violence in communities. And we're in the fight of our lives currently. We are advocating for a $5 billion investment in community violence intervention work. And so we're really proud to join many partners in the Fund Peace Coalition for that work. So it's just a real honor to be here. Thank you to John Jay, and thank you to our esteemed panel for being a part of this discussion. So my understanding is that this conference has been talking about the community violence intervention ecosystem, of which hospital-based violence intervention is a component. So I got to listen into a few minutes of the session prior and recognize that there are a number of really vital interventions that help the development of a citywide strategy to address violence. And I heard Thomas Ack talking about focused deterrence, but of course, street outreach and interventionists are a critical part of this work, peace fellowships, hospital-based violence intervention programs, and many others that focus in on those at highest risk through a targeted set of strategies. And they have a few core components that we see in the CVI ecosystem. So identifying those at highest risk, and there are a number of risk factors. Of course, within hospital-based violence intervention, we are looking at those explicitly who've been intentionally harmed through interpersonal conflict. It may be a gunshot wound, but it also can be a stabbing or another sort of intentional interpersonal harm. As a risk factor, what we find is that 30 to 40% of those who present at the hospital with a violent injury are at risk of returning to the hospital within 5 years with another injury or worse, deceased. So really important to address this high-risk population. Many of our strategies leverage credible messengers. And I believe previous panel spoke about the power of having those with lived experience and credibility among these high-risk clients who are directly impacted. It's a really critical piece of our workforce. They risk their lives being a part of this milieu of care and are often complements to law enforcement and are able to occupy this liminal space of care in the gray area, addressing violence as a health issue with the deep and profound needs that our clients have and needs that they can, or opportunities they can leverage to transform their lives. And that kind of leads to our next component, which is around individualized wraparound care. So critical to many of the interventions, and certainly true within hospital-based violence intervention, is a focus on intensive case management, life coach, housing, and really are really, really critical building blocks for the sorts of transformation we see among our clients who are involved and engaged, might be caught in the cycle of violence. And then finally, and really important pieces are leveraging our relationship with our research and evaluation partners. We monitor progress and transform systems. So we're in it for the long haul. It's about building long-term relationships. Our programs, the door is always open, right? The idea is that as people's lives shift, that these programs are still accessible to people at different stages of life course, and that the systems that are needed, again, like housing services and employment, are able to shift to really address some of the core client needs. We want to break down some of those barriers in systems that prevent people from getting out of the cycle of violence. So these components are really important for a vibrant CVI system, ecosystem that is not only addressing, as I heard Thomas App say previously, violence in the short term, but also looking at some of those midterm and long-term supports. We do want to get at some of the root causes while also connecting to those who are at very high risk, and again, leveraging a credible messengers, these violence prevention professionals who are truly the backbone of our work. So a little bit more about HVIPs. We are programs in which there's an interdisciplinary team. We have violently injured patients who present at the hospital or the trauma center, and are connected to credible messengers who are either employed by the hospital, that's a hospital-based program, or connected to a community-based organization that employs the violence prevention professionals and other supports. And there's a relationship between the hospital and this network of support. And so while there's an intervention, the actual conversation might happen at bedside, we follow patients post-discharge into the community to provide that intensive case management and care, addressing the social determinants of health. And on the right side, you see some of those services: housing, support around victims' compensation, which is a really important site for equity, because what we see is that a lot of our clients are not eligible or aren't aware of victim services compensation, which are supports that can help them with their medical costs or other sorts of expenses. And this is a real site for our staff to really support folks and actually help shift systems. There are issues around, for example, whether a client's deemed cooperative, and that has implications for whether they can receive assistance from victim services. So those are the sorts of things that our programs look at: safety planning, retaliation, and I mentioned earlier, connecting to employment opportunities, legal advocacy, mental health, a whole host of needs that wraparound care. Again, in the long term, we have programs that will maintain support for clients for upwards of 2 years. Many of them are within that 6-month range, but they are the policies that remain open for that intensive care. There have been a number of randomized controlled trials that have looked at the benefits and the power of hospital-based violence intervention. One of the most cited is done by Dr. Carnell Cooper in Baltimore. There have been a number more. Of course, there's always a need for greater research here. And again, the idea that some of the outcomes that are the most powerful in our work is really understanding where clients see transformation. And on a qualitative level, the ways in which they have access to greater employment. So we've seen programs like our San Francisco Wraparound project that shows incredible increase in employment for those who are participants in the program, a decrease in substance use, or a number of studies that elevate other outcomes that are incredibly important, including violent re-injury and reduction of violent crime. I want to pivot now to talking about the role of the media. And as a site for intervention, or a site for being a support to the larger agenda we have, thinking about violence as a public health crisis that merits attention and should kind of drive empathy from a broader community. There have been a few studies. I think it's really interesting to do more. One in Sociology of Race and Ethnicity Journal, one that was conducted by Berkeley Media Studies Group. There are case studies around an analysis of reporting in Chicago, reporting in the state of California, and some of the findings around who is reporting and what is the nature of reporting around violence and crime in these respective jurisdictions, and what implications they may have. So first in Chicago, a study that looked and found that Black victims of homicide in predominantly Black neighborhoods received less news coverage than whites in mostly white neighborhoods. And Latinos were also included in the study, and they found that Black victims were also, they're reporting less news coverage when compared to Latinos as well, which says a lot about the attention, right? And then also we need to kind of focus on the nature of that attention. So we looked at some of the work out of California, many of the news narratives, right? So ongoing stories focused on mass shootings. 85% of news stories focus on specific incidents and include discussion about police perspectives, elevate things like gang relationships, but rarely discuss the solutions, right? Rarely discuss the ways in which violence and transformation of violence can be deployed in these incidents. So when it's about incident response, reporting is about incident response, we don't get to craft new narratives about the public health approach. Both of these studies spoke about the lack of reporting on complex personhood. And to kind of undergird that concept, I wanted to call forth a quote from Latetra Weidman, who's Jacob Blake's sister, who of course lost his life in Wisconsin, in Kenosha, Wisconsin. And she says, when you say Jacob Blake, make sure you say father, make sure you say cousin, make sure you say son, make sure you say uncle. I think really speaking to what it means to share about the complex personhood of those whose lives have been lost, and that those sorts of reporting actually triggers an empathy response, helps us understand the complexity, helps us connect dots between the incidents that we see within communities and a broader perspective about the nature of neighborhoods, divestment, and economic security, redlining in neighborhoods, the ways that structural barriers actually contribute to violence, and then more deeply, how individuals themselves, the trauma and exposure they experience can contribute to their being caught in the cycles of violence. I think those are really incredible. In our work, we've talked to many people who are in the field, who do this work every day. Some of the concerns they have about the reporting they see locally, they often see in the news, at which their preference is to not say things like crime-infested neighborhoods or even urban communities, because they strike this a tone of degradation, but instead saying communities disproportionately impacted by violence, and putting kind of communities first. We don't want to hear words like gangs and thugs, gangbangers, ex-convicts. The field has really moved to saying group involved. Some still say street affiliated, formally incarcerated, justice involved, people who use violence. Again, people first, or introducing new language that helps trigger new ideas about the phenomenon we're seeing. Given the incredible research, we understand why it is that young people are involved in groups for a sense of belonging that can often lead to engagement in violence, or and the exposure to trauma that contributes to those behaviors, and that these sorts of terms really help open the reader to a new understanding. And again, experts in the field use this language. There are notions about victimization that we want to really transform. So innocent victim, right? Triggers the notion that there are victims who don't deserve to be seen as victims. Instead, we want to recognize that all victims are worthy of care, and there's no such thing as an undeserving victim. The trauma, the impact of an injury is incredibly meaningful, not only for the person, but their families, and that attending to their victimization and trauma is part of the solution, right? It's part of the transformation we see. And then finally, Black on Black crime, something we still see here in some places, which is a way of talking about the disproportionate impact in communities of color. So let's name it that, right? Violence is a public health emergency, disproportionately impacting communities of color, not use this trope as a way of excusing or, again, degrading the impact and the reality of the situation in communities of color. So a few other recommendations from the report published by Berkeley Media Studies Group for journalists to cultivate and interview sources beyond the criminal justice system. So engaging voices of community leaders, faith leaders, medical professionals who have a view, who have a perspective about the public health approach to violence intervention. Encouraging those voices actually helps change our expectations about what reporting is. Asking questions about the context for violence. I mentioned this earlier. Let's understand the systemic inequities. We understand that there are limits. We understand that for some journalism, there's a deadline and there are some things, but I absolutely think that there are opportunities, even with those short, pithy incident response, to encourage a look at some of the larger community response or community context. And finally, exploring issues of structural racism, fighting for the connections, the longer form stories, leveraging the editorial board to talk about these intersections. We've seen more editorial boards share their perspective and connect dots, and we find that to be incredibly encouraging. So thank you so much for the opportunity. I look forward to the discussion of the panel. I'll stop sharing my screen now. Thank you.
Thanks so much. I'm going to move right in to Shani and give you the microphone. That was fantastic, Fatimah.
Thank you. And yes, it was fantastic, Fatimah. I genuinely appreciate the opportunity to speak with you all today. As Maurice said, I am an assistant professor at the Violence Prevention Research Program at the University of California, Davis, UC Davis. And we are a multidisciplinary program devoted to using research and policy development. We use science and data to better understand the factors, consequences, and interventions associated with all forms of violence, particularly firearm violence. And then we work to disseminate what we've learned to help inform policies and practices that can ultimately reduce injury and save lives. But the work that we do and that other researchers around the country who study violence do is only as impactful as our dissemination efforts and our ability to crack into non-academic and non-scientific circles. So as journalists and members of the media, you wield incredible power to shape the public discourse about crime and violence. So it's an honor to be here today and share insights and information from the field, from communities that experience gun violence and experts in the field, some who Fatimah just described, the credible messengers, people who commit their lives to intervening and preventing gun violence. I got into gun violence prevention research in 2012. And I moved to Baltimore from Atlanta to start a master's in public health program at Johns Hopkins. And the program began in late June. The following weekend after I started that program, in Aurora, Colorado, a man walked into the opening night of The Dark Knight Rises movie premiere and shot dozens of people. And for the days and weeks after that incident, the media was transfixed on the details and the aftermath in Aurora. Yet people were getting shot nearly every day in Baltimore. And even the local journalists were not covering those stories. But the impact on individuals and families and communities right there in Baltimore, right across the street from where I was at Johns Hopkins, was no less tragic. And by media not focusing on those violent incidences, not treating all gun violence as tragic with rippling effects to touch everyone on both the sides of the victims and the individuals who committed the violence, we send the message that some victims are deserving of sympathy and healing and resources, and others are simply not. And that helps to perpetuate the inaction and stymies the conversation about what to do with this violence. Similarly, I was recently interviewed by a national morning television show about gun violence. And the final segment that aired did not talk about any of the solutions that I discussed during the interview. Rather, the segment fed the false belief that gun violence is an intractable problem. And that narrative perpetuates hopelessness and helps the gun industry maintain the horrific status quo that exists. The conversation about crime and violence has been driven by law enforcement and by actors in the criminal legal system for a very long time. But as researchers and people with lived experience, people who you're hearing from today, as we increasingly know about crime and violence, is that they flourish because of environmental and community conditions. So why are we not talking about those conditions? Why are we not focusing on those in our discussions in the media? with policymakers. What we know about community gun violence is that it is driven by structural and systemic impediments to community stability, health, and well-being. The violence we see today is the result of decades of policies and practices that led to population level and community level disinvestment and neglect. I'm from Birmingham, Alabama. My family is from there, dating back to the early 1900s. And the story in Birmingham is virtually the same as it is in every central city in America. In just my parents' lifetime and the past generation, we've seen racialized terror, everything from harassment to bombings to murders, redlining, restrictive residential covenants, segregation ordinances, and explicitly discriminatory and exclusionary hiring practices, and eminent domain, and deindustrialization, and suburban flight, and the concentration of public housing for low-income families, and all of that resulting in a severely decreased community tax base in city centers. And then as a society, we have prioritized suppressive and punitive strategies and mass incarceration, which has decimated family and community stability and helps to maintain high rates of unemployment and inadequate schools and education, housing insecurity, poor physical and mental health, and extremely restricted financial stability and economic opportunity. And then we've also seen the increased availability of high-powered weapons in civilian hands. And this has now gone on for multiple generations. Gun homicide has been the leading cause of death for Black males 15 to 34 since the 1980s. And the pandemic just exacerbated all of the health and racial and economic inequities we've been living with for decades. We've also seen disturbing increases of both traditionally manufactured firearms and ghost guns in circulation. So I give all of that background because it's important to understand how we got here. And it's important to understand how we can undo the structural harms and stop prioritizing strategies that locate the sources of the structural and social problems within individuals rather than within the community conditions. And I am grateful to you all as journalists and members of the media because you helped to tell that story. And while acts of violence are incredibly tragic and incredibly harmful in the moment, we can't lose sight of how we got here because that is so important to understanding how we undo the harms. The increases we've seen in gun violence demand that we respond urgently and in significant ways in order to reduce it. And the violence we see is not a problem that focusing on suppression and widespread arrest and incarceration and more guns will fix. Fatimah talked about and she mentioned that Thomas Abt mentioned earlier, both immediate and short-term and long-term actions to sustainably decrease violence. And existing and emerging science, as well as the expertise of communities most impacted by gun violence, supports this. The science points to the most effective strategies being those that can operate at multiple levels, that braid together immediate and meaningful support for individuals at high risk for violence involvement with community and systems level shifts in norms and access to financial stability. As Fatimah pointed out, research has shown that the lion's share of gun violence in any city is committed by a small percentage of the city's population. So immediate efforts to reduce violence must be extremely focused on those individuals, those who are at increased risk of violence involvement. The science also shows that most of the individuals who go on to commit violent harm have previously been victims of violence themselves, and they've been failed by the systems that exist to buffer against harm and to support us, whether it be social services, the criminal legal system, juvenile justice system, schools, health care, housing, and economic development. Focusing on only the harm that people commit, not on the harm that was previously done to those individuals, grossly minimizes the role that trauma and prior exposure to violence plays in subsequent violence. The phrase hurt people is a common one in the gun violence prevention world because in order to break cycles of violence, we have to approach the problem of violence as one that requires support and healing. And we need to acknowledge the trauma inflicted when harm occurs, both before and after the trigger is pulled. The phrase healed people heal people is also common because it recognizes that the individuals who have been most impacted by gun violence and have undergone healing and transformation are in the best position to lead community-based violence intervention and prevention efforts. So I know that you all have heard already today about various interventions that have been studied. So I won't spend time going into those unless you want me to in the Q&A. But those interventions, when sufficiently funded and properly implemented with trained and supported staff, have shown significant reductions in gun violence in the neighborhoods where they've been implemented. But it's important to understand that these programs cannot operate in vacuums or as standalone interventions. They have to be integrated into an infrastructure of community violence intervention and prevention so that there is that interagency commitment from multiple levels of government and across various sectors to address those systemic issues that I talked about, that how we got here, and to provide substantial funding and support for the programs and their staff so that the interventions are part of broader efforts to provide affordable and secure housing, living wages, access to quality healthcare and education, and opportunities that empower communities and individuals to thrive. And we have this once in a generation opportunity to begin to repair those structural harms through the American Rescue Plan dollars, as well as the $5 billion commitment that the Biden-Harris administration has made to invest in community violence prevention and intervention. And so, we rely on you all as journalists and reporters to ask critical questions of the systems that we have deferred to when it comes to public safety and first response. We need to have conversations about what types of interventions those who are most impacted by gun violence support, what kinds of community needs are necessary in order to improve those environmental conditions that allow violence to flourish. And we need to really be critical of the deference to law enforcement and the criminal legal system, because when we understand that violence is a public health issue, that violence is a symptom of poverty and disinvestment and trauma and perceived hopelessness and desperation, how are those interventions, how are those systems addressing those issues? And what kinds of support should be in place? And we need the conversations around complex personhood, as Fatimah just pointed out, the research that has shown that there is a lack of devotion to understanding the humans behind the victimization when it comes to Black and Brown victims, and even those who commit violence. There is a real need to understand how we got here, and for you all as journalists and members of the media to really uplift those stories and help the public recognize that all victims of violence are deserving of attention, and all victims of violence are deserving of a real action to address this as a public health problem that is not intractable, that is preventable, and that we all benefit from with true solutions and true community empowerment. So I will stop there.
That's quite a stopping point. Thank you. Dr. Romo, tell us about what you're doing out there, and you're sort of like the other end of what Fatimah and Shani have been talking about. You're on the ground, you're doing it in a specific program.
Yes, indeed. Thank you. I'd like to share my screen, please. Can you guys all see my screen? Okay, thank you. Well, thank you very much again for having me here. And I want to just thank all of the current panel members that have presented. Thank you all for your excellent presentation on highlighting both the effects of gun violence and the intervention efforts that are being taken both at the national and at the local level, and bringing it back really to the communities that are being affected here. I'm going to talk briefly, just a couple of slides about the program that we have here at Jacobi, Stand Up to Violence, which is based on the Cure Violence model and is our New York State's only hospital-based violence intervention program that we have here. Speak a little bit about how we were established, what we're doing here, and go through some of our community and hospital data that we have here. So our program is one of 12 what we call Snug street outreach sites. Snug is New York State's violence prevention initiative that started in 2012. It's gun spelled backwards. Initially was focused on the Cure Violence program with community violence initiatives spread throughout the state. We are funded through the Division of Criminal Justice. And our program here at Jacobi started in 2014. And we target specific blocks and neighborhoods within the 43rd, 47th, and 49th precincts. And all of these areas were based on our local NYPD data, looking at 10 years worth of data prior to our program inception in terms of both shooting victims and homicide rates, and also looking at our hospital data and looking for the areas from where our patients were coming from primarily. And along with having the community-based intervention where we target at-risk youth, we also have a hospital component, and I'll get a little bit more into that in the coming slides. We are outreach workers. We have a network of 6 outreach workers that live in the areas where we are targeting. And our outreach workers are credible messengers, as that word has been thrown out recently at a lot of these presentations. And who that is, those are people from the neighborhoods who have similar experiences to what a lot of the at-risk youth is experiencing, predominantly young men between the ages of 14 to 25 who are deemed to be high risk for either being involved in some type of active community dispute that results in violent trauma victimization, or have indeed been victims of violent trauma themselves. And we also have a hospital responder who's a person that is based strictly out of the hospital, who's also from the local community, who sees every single patient who is admitted for violent trauma, along with me and a social worker. And by employing all these individuals, we're not only providing a service to the community, but we're also providing employment for individuals who might otherwise not have found employment themselves. And we are essentially a model for some effective reentry practices, one of the state's largest models for this reentry programs, given the fact that a large majority of the people that we employed are previously incarcerated individuals or individuals with a criminal record who have not otherwise qualified for many jobs. So just a brief summary of our programs. Like I mentioned, we have a hospital and a community component. So at the hospital level, we respond to every single patient who was either shot, stabbed, or assaulted if you're the victim of a violent trauma. And our inpatient hospital team consists of myself, 3 social workers, along with a hospital responder who's a community outreach worker, and along with a community outreach worker who's from the community, who's not based out of the hospital, if indeed the person we are responding to is from that neighborhood from where this individual is from. We obviously help coordinate the medical care. The most important thing to do initially is to actively counsel against retaliation and provide effective conflict mediation strategies, provide support, and then try to really get a sense of why that individual was victimized by the violent trauma. What was the dispute that led to that person's victimization, and then try to then allocate resources at the community level through using our community response to mediate that active dispute between whatever neighborhoods or individuals were involved. At the individual level, we have a network of 6 outreach workers. Again, these are our target areas that are highlighted here. They are all based around a lot of the public housing complexes in the Bronx in New York City. And they engage community participants. They have 15 participants per each outreach worker, and they essentially act as mentors for them, providing employment services, providing conflict mediation strategies, providing any educational opportunities, but mostly just, being around and providing an ear for when they do have these active conflicts. And they're always trying to look for active disputes in the community that have resulted in some of the shootings. We do something called shooting responses, where every time there's a shooting in our area, we essentially have a community rally and a peace walk in that neighborhood to just make it clear that somebody was shot in that neighborhood. As Ms. Bugg stated, there is decreased media coverage when individuals are victimized by violent trauma, right? In places like Baltimore and elsewhere, these shootings become so commonplace that it becomes almost part of the norm. And when we go out to these communities where individuals are indeed victimized, is to showcase the community that, somebody was victimized here, if not killed. And it is a big deal that we should all be talking about it, and also try to get resources to that community. So our main goal is to change both behavior in the community and also change hospital norms, meaning by changing hospital norms, what we're saying is we're trying to change kind of the way violent trauma is viewed, and trying to change the way in which we treat violent trauma. And that we're not just treating, the individual wounds that we are seeing. We've kind of mastered that part of it, but is getting more to the sense of what is the root cause of why this individual is victimized, what led to their injury. In the same way, if somebody gets admitted, let's say, for an asthma exacerbation, right? My job as a pediatric hospital is to figure out not just why they came in, but was it because they weren't taking their medicine, they didn't have access to their medicines, or maybe they don't have good education regarding what asthma is. So we need to take a prevention arm as well as an intervention arm at the same time. In terms of what our numbers look like since we started, so when you look at our program, we started in August of 2014. In all of our target areas, we had a combined 28 shootings during that year before. Since we started, we saw a gradual decrease in the number of shootings in our target area, except for last year. 2020 was a little bit of an anomaly. I know it was mentioned in terms of the increased homicides and shootings that we saw throughout different communities in the United States, predominantly Black and Hispanic neighborhoods, where there was a significant increase. We had a 160% increase in the shootings in the Bronx last year, and this year also compared to previous years. So post-COVID, we have definitely been victims of this. However, what we have seen is since January, things have kind of leveled off a bit compared to where we were last year, and we're hoping that our numbers will not continue to climb to where we were. However, when we looked at 4 years worth of data, when we compare 2014, 2018 to 2011, 2014, what we saw is that we had a significant decrease in the incidence rate of community gunshot wound victims. We went from 8.1 per 100,000 to 4.5 per 100,000, with a chi-square of 14.8 and a p-value less than 0.01, which suggested that we had a statistically significant difference in the community GSW incidence rate in our SUV target areas compared to the 4 years prior. Farm-related homicides also decreased instead, except for last year where we had a significant increase in the number of homicides. Again, post-COVID, we had a significant increase in homicide we saw in our target area as we saw throughout the Bronx. So far this year, knock on wood, we've had 2 homicides. But what I tell people is that these numbers are not emblematic of the effect that these homicides have on not just individual victims, but families and entire communities. Whenever one individual is lost to gun violence, that's somebody's father, that's somebody's brother, that's somebody's son. And not just that, when we talk about the actual cost of violence and violent trauma, we talked about what we call lost productivity. And what that is that individual who passed away is their inability now to not only attain a job, but attain higher education, provide to society. You talk about a $65 billion a year that is lost from this country in terms of lost productivity of every single individual who was lost to gun violence. In terms of the patients that we have seen, as you can see here, we had a little bit of a trend up until about 2019. So if you look at gunshot wounds are here in orange, stab wounds are in yellow, and assaults are in green. And as you can see here, up until like about 2020, our number of stab wounds were outnumbering our number of gunshot wounds. And that was predominantly because there was a decreased availability of guns. We had a lot of interventions and our gunshot wound numbers were down. And then what we saw starting last year is that our number of gunshot wounds far outnumber our number of stab wounds. And this year already, this was as of the end of last month, we are already at 102 gunshot wounds compared to all of last year when we were at 75. So here, in terms of our data, we have seen a 170% increase this calendar year in the number of gunshot wound victims that we are seeing here at Jacobi compared to last year. We are the only level 1 trauma center here in the Bronx. We have been significantly affected by not just a COVID pandemic. We were at the epicenter of COVID in the March of 2020. The Bronx had the most deaths and cases per capita of COVID in New York City. And now we have the most deaths and cases per capita of gunshot wounds in New York City compared to anybody else. So we've had one global pandemic followed by the epidemic of violence. So much so actually that we had to take the emergent step of having a trauma surgeon stay in the emergency room 24/7 and not leave because especially on Thursdays, Fridays, and Saturdays, because there was so much trauma that we needed to have extra hands on deck because there were so many traumas coming in that we needed to have a surgeon literally living in the emergency room and not able to leave to just quickly address a lot of these issues. It really has been relentless. Last month specifically was horrible. In June was the worst. This month so far things have slowed down a bit. And it actually is following a pattern. What we notice is that as COVID cases go up, the violent trauma goes down. As COVID cases go down, the violent trauma goes up. Right now, we are seeing a steady increase in COVID cases, and not surprisingly, our gunshot wound victims are down. When our COVID cases are down, we've seen a lot more gunshot wound victims. This was data that we did. This is a paper I just submitted for publication that hopefully will be accepted soon. We looked at data of our patients from 2014 to 2018. We had prospective data of individuals who were admitted to our trauma center of ages 15 to 24 that we followed over a 4-year period to see if our intervention worked. We identified a total of 535 individuals, the majority of whom were male, and not surprisingly, the majority of whom were Black and Latino in our population here in the Bronx, and the mean age was about 19. So the main outcomes we looked at was of those patients that we saw, did they attend more than 50% of their scheduled follow-up visits, and did they come back for a violent re-injury during that time period? And what we found was that individuals that we intervened in had about a 2.3 times odds of coming back to more than half of their scheduled follow-up visits, which was a marker of morbidity, basically, and saying like, are you adherent to your medical plan? But those patients that we saw had also 0.4 times the odds of coming back with a re-injury, which essentially means that patients that we saw had a 59% decrease chance of coming back for re-injury compared to those patients that we were not able to see. So we were able to significantly decrease the incidence of re-injury in our patients and significantly increase our rates of follow-up in the patients that we were able to intervene in. So just as a summary, again, we were established in 2014. We're funded by the New York State Department of Criminal Justice. We have a hospital and a community component. Here's a brief summary of the staff that we currently employ. We've seen over 1,300 patients. We were able to effectively decrease the rates of re-injury along with improving the rates of follow-up. When we look at our data up until June, right now, we have a total of 38 active community participants. These are individuals in the community who are deemed to be high risk, who we are currently mentoring now. We have been involved in over 400 active community disputes that we have been able to mediate. What we don't know is how many shootings those mediations of those disputes prevented. There is no number I can give you for that. I can't give you a p-value or an odds ratio to tell you, us mediating this community conflict resulted in this decrease in shootings. We just don't know what that number is. However, despite this year, the Bronx has seen a 78% increase in shootings overall and a 41% increase in homicides to date. However, in our target areas, we have seen a 10% shooting decrease year to date and a 33% homicide decrease year to date. So although the numbers are up in the Bronx, the numbers in our target areas are slightly down, not down enough to the point where we feel comfortable saying we're being successful, because I would like to say if there's a single shooting in one of our target areas, we are not succeeding. But I think we are doing at least better than the rest of the Bronx is doing, which is evidence that our program is being effective. We were recently identified by New York State as the best in-class model program with funding that has been made to try to replicate our program throughout the state, to have a network of hospital-based violence intervention programs throughout the state because of how effective we have been to expand. And also we've also recently received increased funding also by New York State to expand our outreach workers, and we're going to expand to a different section of the 43rd precinct and the Soundview section of the Bronx, given our hospital data noting that we had an increase in shootings from that area and patients come in. Now we're going to have an active community component there as well. And we've also received some increased funding from the city from the mayor as well to expand our program through other parts of the Bronx and in the hospital. So with that, I will leave it up for the Q&A session and if there are any questions.
Thanks very much. I have a question for Fatimah, and then we can, I think there might be some questions in the queue, which is, so you're in all these places. How do you get there? Who comes, you know, how does that sort of work so that somebody call you up on the phone and say, come in, help, you know, how does that work?
Yes, it is actually often that Dr. Romo knows this, the movement of engaging hospitals, trauma surgeons, the healthcare professionals in this fight has been evolving over many years, and we've really hit a critical, I think, kind of nexus, and I believe that there's just a lot more interest. So we have great partners at the American College of Surgeons. We have wonderful partners who are kind of saying this hospital-based violence prevention is a powerful evidence-based, evidence-informed model, and you should have one if you have high rates of violence in your community. And so we are at times contacted by a trauma surgeon. We're contacted by community leaders, organizers who are fighting and very much want to see transformation in their own communities, and they want a partnership with their hospital and want to build those relationships and sees the hobby as a place to kind of mitigate and kind of think through those partnerships. Sometimes we will have an attorney general or district attorney reach out and say, I want to rethink public safety, and we find this model very interesting. What can we do? How can we learn more? So it really does range, and the power of this is the peer learning. It is that we have a Dr. Romo, we have another doctor sharing how they've approached the work and where those best practices are, and that really we have an annual conference that brings over 120 cities together in the United States and progressively internationally to share best practices and to kind of offer up the data, just as Dr. Romo has, about the power of this work on the ground. And people are able to ask questions. And so I actually recall in a breakout room last year, because of course our conference was digital, talked to a staff at a particular hospital. They said, we want to kind of grow our program. And lo and behold, we're there to really help support the development because there are stages. Dr. Romo was talking about bringing new scale, hiring new staff. Those are at every developmental stage of programming. There are new needs, new things to negotiate. And so, that's where we come in.
I have one quick question for Dr. Romo too, that occurred to me. And you're talking about people who come in who are victims. And so they are also potentially witnesses. And so you must have the police, there must be interaction in that sort of, how does that work?
Yeah, it's always challenging dealing with police. I always like to say we treat victims as victims and patients first, even if they are currently active under arrest. Unfortunately, a lot of the police here in the NYPD treats them as criminals first, other than victims. So I always have to have that constant conversation with police officers of how they are patients and they're not criminals. But it's always tough. I think when patients are under arrest, particularly hard to talk to them because they're not going to be so open to speaking with me or with our outreach workers because they don't want to disclose anything around the circumstances about what happened. What we do tell our patients is when we are able to speak to them in confidence is that, we are not, going to disclose any information to the police or anything. We do whatever notes I write in the medical chart, I actually keep pretty vague in terms of what I'm told. Is that, if it was, I say, something vague in the point of like, patient, disclose that injury secondary to active community dispute, that's it. And any information we get is confidential. We don't share with the police any leads we get. If we identify individuals who were involved in the shooting or in the assault, then we send our outreach workers to mediate that dispute with those individuals, but the police is not involved. We have gotten to the point where we do have a kind of symbiotic relationship with the police. It's not a direct relationship, but they know who we are and they know what we do, but they don't get involved in what we do. And we've gotten to the point where they just kind of leave us alone and we leave them alone. If they see our outreach workers mediating a dispute, they know who they are and they let them do their work and they don't interfere. And we've gotten to the point where even some police officers will tell our outreach workers, hey, there's this kid over there, this individual, we're a little worried about what he's up to. We don't want to arrest him. Can you guys just go and talk to him or put him into your program? Which is what we want. You know, we don't want the police to go arrest individuals or do that. So I think we've gotten to a point with some precincts where we're at that point. It's obviously a work in progress, but that's currently where we are.
So changing the culture. Go ahead, Steve.
If I can just follow that up, because I think it's a great question. It's along the lines of what we've been talking about earlier in the afternoon. So is this the kind of agreement you have with individual cops, or do you do it you have agreements at a precinct level for cops to stop at the front door of the hospital? And if that's the case, what kind of buy-in are you getting?
So it's a long time buy-in. You know, as you can tell, we work a lot with the precincts. We have a relationship with all the precinct commanders. They know who we are. We get presentations to them. We have a community liaison, individual named Pastor Gooding, who's a pastor in the community, who has relationships with a lot of these precincts. So through him, we're able to kind of get the information across of who our outreach workers are. So, you know, like I said, we're not directly linked with the police because we can't be, because then we would lose our credibility. But they do know of us and we know of them. And the point is to say, we like to say we are proactive and the police is reactive, right? We like to prevent the violence before it happens, and the police responds to the violence once it's already happened. So, you know, I think they're starting to realize how we're making their lives a little easier, because if we're able to mediate a dispute, then they don't need to get involved. And I think they'd rather not get involved in a lot of these issues.
So I want to extend that question to Fatimah and Shani as well, but we also have a bunch of questions stacked up. So let me just go to them, those questions first. There's two that are specifically really good media questions. One is from Andy Grimm, who asks, what are some of the discrete stories you'd like to see in the public health approach to violence? So you've all talked about the wide-ranging long-term interventions that are necessary. So how does the media tell the story? And what more specifically is a statistic and trend that could be a story? And very similarly, Jay Gilmer asks us, how can we get the media to cover positive violence prevention solutions that work every day in neighborhoods? And I'll throw that out to both Shani and Fatimah for their responses.
It's a really great question, and I would recommend going to, and we could probably pull some of this together. I've been really pleased to see that journalists are already beginning to do this, and the Trace as a kind of a resource that's an online publication that focuses on gun violence has done a really great job and has built relationships with all of us to then source conversations about this. So talking about the intersection of COVID and violence, understanding some of the, but again, complex personhood doesn't take much, right? It's about, on a very tactical level, it's about recognizing, it's naming the trauma, it's naming who the person was before they were shot. I mean, it can really be about the kinds of questions you ask, you know, what does this young person love to do? Or, you know, how do we understand their family? I mean, those are the sorts of things that at a very micro level can be really powerful. But again, broadly, shifting narratives means we're taking a different approach, and it's elevating some of the powerful work of interventions, and specifically here, and I think this is really key. There are the kind of human interest stories, right, that are about kind of like, let's talk about this great single program, when this is really a robust movement. This is a robust movement that is now on the precipice, right, of securing a $5 billion investment from the federal government. And we're not there yet, but we're close. It's when we talk about a paradigm shift, we have to pay attention to how our law enforcement partners are viewed by the public as an established institution, that and that we are kind of seen as separate programs, although what undergirds our work is this profound ecosystem. It's a paradigm shift. And so encouraging us to think about the infrastructure of community safety, including a public health approach, is, I think, the way to go in terms of like shifting that narrative, so that folks understand it not as these separate programs, but as something that has a deep underbelly of research. It has an underbelly of the conceptual that like participation of these incredible community violence intervention specialists, elevating their work as a workforce, are really great ways to kind of get at some of the questions you've raised, and try
That's
things.
a powerful phrase. No. It's a powerful phrase, the infrastructure of public safety. That will delight the wonks among us, but I think it fits, and people are talking about that. Shani, do you want to respond?
Fatima covered all the bases. I don't really have anything else to add. I think I just will underscore the importance of really getting close to those who are doing this work. The work has been happening for a long time. It has been chronically underfunded, chronically unsupported, and yet there are people who have devoted their lives, 20, 30 plus years, to do this work because they see the need, because their neighbors and their friends and their family members are dying. And so I think building those relationships, Fatima lifted up the Trace. I will also shout out the Trace for the commitment to, and organizations like Berkeley Media Studies Group that are committed to changing that narrative, shifting the narrative, and incorporating other voices besides the same ones that we have typically relied on to talk about what violence looks like, because that's how we shift the narrative.
We have a bunch of Trace folks in our audience today, so I'm sure they'll be glad to hear that. A final question it's a question that I thought of too after hearing Dr. Romo speak. It's from Leah Skinny, who asks, can you explain why we're seeing this trend of fewer gun violence victims when COVID cases are spiking and vice versa? I think Dr. Romo is still in the audience. Well, maybe he's not. I don't see him.
Dr. Romo had to run out to a patient.
Okay. Anybody else want to try a stab at answering that?
I think that there are many a study that will help us disentangle some of what we've seen in this last year. We're still so close to it. I think we're seeing things on the ground that we're still trying to understand. What I would offer is some conjecture. Maybe that's what you're asking, but I'll give it to our resident scientist here to see if she has any thoughts. But I will say just in general that, it's been fascinating to see what our programs are observing on the ground, that there are a number of trends of certainly the influence of shelter-in-place orders on kind of the spread and the distribution of violence. There are other sorts of impacts, right? There's less supply of the essential things that folks need. Is it fear on specific street corners that driven by maybe people being affected? But there's a whole host of possibilities. It's really hard to put a finger on it, but I'd love to hear Shani's thoughts.
Yeah, as a researcher who relies on data and evidence, I will not provide conjecture, because I think there, as Fatima said, there are so many different factors at play, and what's happening hyper locally is really important. And so sitting from Sacramento trying to, guess at what's going on the ground in the Bronx with COVID cases and violence would be irresponsible for me as a scientist and a researcher. But I think that I'm equally interested and would love to learn more, because I think that trend does contradict some of the trends that we've seen elsewhere. And so I would love to learn more. And I'm sure Dr. Romo is eager to study that as they get more data.
Okay, we'll have to leave it there for now. This has been a great session, and I really do appreciate, those are wonderful slides as well. And again, please send them to us if we don't already have them, and we'll post them on our site. So we'll take an abbreviated break to just stretch our legs, and then we'll go into our final session of the day. But thank you both very much.
Thank
I hope
you.
can stay with us.
Very much.
Maurice?
Appreciate it.
Thank you. Take
Great.
care.